All right, we can get started. Good evening, everyone. Thanks for joining our program. I'm Dr. Nick Blondin. I'm a neuro-oncologist at the Smilow Cancer Hospital. Associate Professor of Neurology and the interim director of our clinical research team. Dr. Malterno was unavailable this evening. She asked me to step in to help moderate this program, which I was happy to do. Here's our agenda. After a brief introduction, we'll hear from Dr. Barden on medical therapies for brain tumors, and then Dr. Kim on surgical therapies for brain tumors. Then I'll give a few slides on our clinical trial portfolio and clinical trial treatments for brain tumors, and then we'll have a question and answer panel. So in the Zoom features now, there's a button Q&A, and you can put questions in there. As they come in, we can review the questions and either answer at the end of the segment or at the end of the talk. Thanks again for joining. We'll be moving on to Dr. Kim's presentation, Dr. Barden's presentation first. Dr. Barden is an assistant professor of neurology at Yale. She is also the associate director of our neuro-oncology fellowship program. Dr. Barden received her medical degree from Yale School of Medicine and completed her residency at Yale New Haven Hospital. She also completed her fellowship in neuro-oncology at Yale. So I guess go Bulldogs. Right, Dr. Barden? So yeah. I'll stop sharing screen and let her take over.
Yeah, my bio just is Yale. I came here for med school and never left. That's the one-liner, but for good reason. Yale's a wonderful place. Perfect. All right, good. So this should be in the presenter mode. Can I get a thumbs up? Thumbs up, love it. All right, thanks so much, Dr. Blondin. Hi, everyone. As Dr. Blondin said, my name is Miri Barden. I'm one of our neuro-oncologists here. I'm going to take my time to talk about the medical therapies, like Dr. Blondin said, but first to maybe take a step back and a broader look at just understanding what a brain tumor diagnosis is, and trying of outlining what the language and how to navigate these things. So we'll start quite simply, right? What is a brain tumor? Like any other cancer or a tumor, a tumor is an abnormal growth of cells. Right in line. It's an abnormal growth of cells, but in this case, specifically in the brain. Brain tumors can be malignant or cancerous, right? Or they can be benign tumors that are non-cancerous. I always kind of put benign in quotation marks when we're talking about brain tumors, because even something that's benign or not cancerous, doesn't require chemo, when it's in the brain, tends to cause problems, tends to cause symptoms, and these symptoms can be pretty debilitating. So really nothing in the brain ends up being benign. Management of brain tumors is pretty variable. We'll talk a little bit more in detail tonight. We'll hear from Dr. Kim and Dr. Blondin, but in general, can involve perhaps just surveillance if something's benign and not growing. Can be a combination of surgery, radiation, or even chemotherapy. We've done this. There we go. All right. So when I'm talking about brain tumors with patients or introducing them to students for the first time, I like to put them into two broad categories. The first being what we call primary brain tumors. These are tumors that start in the brain and grow there, and pretty much where they remain. And then there's secondary brain tumors, which are really brain metastases. These are tumors or cancers that start elsewhere in the body, and then through whatever way, usually through blood, spread through the blood, will find their way to the brain and then form a secondary tumor there. These are treated and addressed very differently. The primary brain tumors really are something that we as neuro-oncologists will primarily manage together with the neurosurgeons. For brain metastases, often a medical oncologist or a hematologist will be involved as well, and they're the ones that are treating the primary cancer, and we're assisting with the disease that's found its way to the brain. Primary tumors, primary brain tumors, there's a lot of different types, over 100, or I think over 120 particular types of primary brain tumors. They come from all different aspects of tissues, both the brain tissues itself, the covering of the brain called the meninges, lymphatics, sort of the immune system of the brain. You can have cancers that originate from there called CNS lymphoma. But glial and meningothelial or the meningiomas are the most common. And primary brain tumors are graded from 1 to 4, 1 being the benign, or sort of the ones that you don't have to worry as much about, and 4 being the most malignant or aggressive. Brain metastases are sort of by definition are going to take a cancer that someone has and make it a stage 4. You have melanoma, you have lung cancer. Once you develop brain metastases, that is now a stage 4 cancer. The most common types of metastases we see are really the most common types of systemic cancers. So lung, breast, melanoma, we'll see in the brain, not infrequently. And I do find, and I think Dr. Blondin will probably agree, as all these advances in how we treat systemic cancers are coming along and patients are living longer and doing well, we're seeing now brain metastases in systemic cancers that we didn't really before. Part of that is a testament that patients are living longer, and so we're seeing these complications. This is just to give you a sense of primary brain tumors, what is occurring most frequently in patients. This is a look at our 5-year span between 2013 and 2017. You can see that the 2 most common types of primary brain tumors are going to be meningiomas here in the dark blue and glioblastoma here in the deep colored red. Meningiomas are the most common primary brain tumor in adults, are really the most common brain tumor in adults overall, most of those being very benign. Glioblastomas are going to be the most common malignant primary brain tumor in adults. So how is a brain tumor found, right? First, it can be that a patient develops symptoms, right? The brain is obviously important for controlling a lot of important functions, how we interact with the world, seeing, communicating, our language, moving our arms and legs. And so when you have a tumor that forms in any part of the brain, you can, of course, start to have symptoms that sort of relate to that particular area that's affected. You kind of maybe hear more frequently about the signs and symptoms to look out for stroke. The same would apply here. Usually stroke symptoms are going to come on very quick, whereas in the case of a tumor that may be growing, it's a bit more slowing over the course of weeks to maybe months. You may see increasing weakness on one side of the body, increasing confusion, language problems, things like that. The symptoms may not be related necessarily to the particular area that the tumor is in, but just because the pressure is increased overall. The skull is a fixed space, and there's room for the brain, and there's room for the spinal fluid, and that's it. And when something else starts growing in there and taking up that space, our brains really can't accommodate it all that well. And so we start to get things like bad headaches, nausea, vomiting, and sometimes being more lethargic, or sleeping, not waking up as well. So that's another type of presentation that we can see. Another is seizures, right? That's a common thing that we can see in the brain. A number of different things can cause seizures, doesn't have to be a tumor, but certainly if somebody develops new seizures, particularly if they're an adult, we think about a tumor. And so that's something that we'll look for. In the case of patients that have systemic cancer, so a lung cancer, for example, sometimes brain metastases are asymptomatic. There's no symptoms related to them, but they're just detected on what we call staging imaging. Anyone here who has a diagnosis of a cancer is probably familiar with getting staging imaging of the chest, the abdomen, and pelvis. And depending on what type of cancer that you have, so often we'll get a staging MRI of the brain as well. And sometimes we just incidentally pick up metastases there, without necessarily the symptoms having developed. And sometimes they're incidental, right? Somebody gets into a car accident, they have a concussion, what have you, you go and get a CAT scan and there's an abnormality on it. Often those incidental findings are meningiomas, which by and large, we don't need to do much about. Things duplicated. So somebody comes in with these symptoms, right? They have a seizure, for example. An adult has a first-time seizure, comes to the ER. How does their hospital course unfold? So the first thing is they're going to get imaging, right? Probably a CAT scan to start, but that will be shortly followed up by more advanced imaging techniques like an MRI. That will show us, not only where the tumor is located, but help give us an early sense of maybe what type of tumor we're dealing with. They can look a bit different on MRI. but we can make good guesses as to what type of cancer or what type of tumor we're dealing with just based on the way that it looks. The next step is to confirm what it is. And that's where Dr. Moliterno's team and Dr. Kim's team comes in handy. This is actually Dr. Moliterno. You can't tell, she's got all her stuff on. But this is her in the OR doing what she does best, and that's getting tissue. In primary brain tumors, things like gliomas, lower grade and glioblastoma, that surgery is going to be trying to remove as much of that tumor as safely as possible. And I'll let Dr. Kim tell you more about that, and it's her area of expertise. But that's going to be the next step. And often the same hospitalization, you come in with seizure, we find the tumor, we characterize it. Dr. Moliterno gets you in the OR in short course and gets that surgery done. And the recovery time is usually pretty short in my experience with her patients. After that, okay, you've done the surgery, what happens? This is where we make that diagnosis. We have an expert team of neuropathologists here, geneticists that do sequencing on the tumor DNA that help really pin down what exactly the type of tumor that we're dealing with is and what particular actionable mutations there may be that help guide our therapy. This right here, I won't go through in too much detail. Anyone who has a glioblastoma or has a loved one who was diagnosed with one will be familiar with the schematic that I have in front of you. This is our standard of care treatment for glioblastomas. You can see the citation here at the bottom is from 2005. That's, I mean, 20 years is probably a long time by any standard, but in the area of medicine feels like eons. And I put this here to make the point that we, in spite of all of our hard work in neuro-oncology, we still have not improved upon this treatment schema that we use. Nothing's really topped it as a standard of care. And Dr. Blondin will tell you more about the hard work and the clinical trials that are going on to help improve upon this. But this right here is really what we got in terms of our first line gold standard of how we treat patients with glioblastoma. Starts with the resection, removing as much of the tumor as safely as possible. And then it's going to be a combination of chemotherapy. It's a chemotherapy pill called Temodar or temozolomide, and radiation. And the radiation's done by our radiation oncology team here at Yale, and then our Smilow care center sort of satellite sites. We have radiation oncologists out there as well. And it starts with in most cases, it starts what we call a concurrent phase of chemo and radiation. So patients will be getting radiation for 5 days a week for 6 weeks, targeted to the area where the glioblastoma was. And at the same time, they'll be taking the chemotherapy pill called the temozolomide. After that, they'll get a bit of a break, and then we'll be doing additional cycles of the temozolomide. There's other factors that play into this, and we make modifications to this regimen depending on both patient-specific and tumor-specific factors. But in general, this is going to be the standard of care. I'll just take a couple minutes to tell you quickly about the majority of what it is I do with our neuro-oncology group here, and then I'll pass it over to my colleagues because I want to make sure we have time for questions at the end. So I do see patients in the office, and I noticed a couple of familiar names on here. Thank you guys for coming. But the majority of what I do is not necessarily in the office, but in the hospital itself. I'm a neuro-oncologist, but I'm also a hospitalist in many ways, taking care of our neuro-oncology patients when they're admitted with complications, be it seizures, bleeding, tumor progression, what have you. And I believe this is an important job. It's one that is a bit novel here at Yale. There's some other places, I think Memorial Sloan Kettering has a similar type of model, but it's not one that you find everywhere. And I think that it's something that's incredibly important to taking excellent care of our patients. Patients with brain tumors are usually admitted to the hospital at really critical stages of their disease course, either when they're first diagnosed, which is a difficult thing to go through, when it comes back or relapses, or at the end of life, and all the serious complications that can happen in between. And perhaps even some of you on the Zoom can attest to when you're in a place, where it feels like there's one doctor, there's another doctor, you're getting all these mixed messages, you're getting confused, you don't know what happens next. Having a seasoned, strong neuro-oncology presence to help guide that management, provide context to the other specialists that are involved in your loved one's care, and really ensuring that seamless communication and transition back to your primary neuro-oncology team in the outpatient setting is crucial to making a successful optimized hospitalization and one that is not prolonged with unnecessary testing and minimizing confusion to patients. And so oncology hospitalists or neuro-oncology hospitalists, in my case, are really physicians who specialize in this type of care. They specialize in neurology and oncology, but also in the care of hospitalized patients, which is a bit of a different thing than taking care of patients in the office. You have to work with the multidisciplinary team, nurses, APPs, pharmacists, social workers, all of the others that you see listed here. It's truly a collaborative effort, a team sport. And because we're focused on taking care of patients in the hospital, we're really positioned to know how to make things happen quickly and how to move along a hospitalization and how to get people out of the hospital as soon as they're able. Our focus is on improving quality and efficiency of care and getting patients really back home safely and as soon as possible. So with that, I will release my sharing to my colleagues here and we'll continue.
Thanks so much for sharing, Mary. That was a great overview of our treatment. Definitely agree. It's difficult to use a standard of care that was developed essentially 20 years ago for first-line treatment for patients. And hopefully we'll be able to improve that soon. Do think that addition of some therapies like Avastin and Optune device for patients that are able to use that treatment also does help somewhat. Those are other FDA-approved therapies for glioblastoma, but compared to other cancers, we haven't had the major breakthroughs that have been seen. In particular, immunotherapy doesn't seem to have a major breakthrough in neuro-oncology yet, whereas in other cancer types like melanoma and some forms of lung cancer, it's really been just a major breakthrough. I think like former President Jimmy Carter, an example, he had metastatic melanoma with brain involvement and then survived for a number of years in his 90s after that treatment due to immunotherapy. That was a disease before the immunotherapy era that was usually fatal within weeks. So these major breakthroughs have happened in the last decade. Hopefully they're coming to primary brain tumors soon. Thanks again. All right, for our next segment, Dr. Kim will be talking about surgical treatment of brain tumors. Dr. Kim is a neurosurgical oncology fellow at Yale. Dr. Kim works with Dr. Moliterno in the operating room and helps manage our patients in the hospital. She received a PhD and medical degree from the University of Illinois and completed residency at Loyola University in Chicago. She will be moving to Seattle at the conclusion of her fellowship to continue providing neurosurgical care for patients. The next phase of her career is in attending. All right, Dr. Kim.
Great. Thank you so much for that intro. Let me just get this going. All right. Can you guys see my slides? Perfect. So some of these might look a little bit familiar. Dr. Barden has inspired some of these some slides for me. So just really briefly, I'm going to talk about the role of the neurosurgeon within this whole group in terms of neurosurgical oncology care. So, again, just to review the primary brain tumors versus metastatic tumors, there's a whole variety of them. Some come from the brain itself, and then the other tumors that go to the brain might come from other parts of the body. And all these treatments that we have for these brain tumors, they include surgery, radiation, chemotherapy, maybe even immunotherapies, or a combination of all of the above. And it really takes a team to get everything together so that we can have good, seamless, coordinated care for all our patients. I really like this little schematic that Dr. Barden had put together. So I just updated a few pictures with the flow of advanced neuroimaging, and then how something like this, when we see it on a scan, might sort of prompt a visit to the operating room. And here you see Dr. Moliterno, and again, Moliterno with me and our chief resident. working on some tumors. And then this is what we might see from the specimen that we get. You know, the pathologists and a whole slew of people will sit there and analyze the tumor tissue that we get from the operating room so that we can, you know, understand what the pathology is that we're dealing with. So, you know, really it takes a multidisciplinary assessment of the patient so that we can care for you guys, you know, all our patients pre-op, perioperatively in the hospital, like, you know, right around the surgical time, post-operatively, and then all throughout treatment, depending on the types of treatment that you might need. So, you know, this is a whole group of people that make up the teams, the neuroradiologists, neuropathologists, our neuro-oncology colleagues, the critical care team after surgery, other neurosurgical colleagues, radiation oncology, as well as all our support staff. So these are the APPs and the nurse practitioners that we have in the hallway or on the wards and in the outpatient setting, as well as palliative care and hospice care, our pharmacists, and then our PTOT and speech people that help all our patients post-operatively to get back up on their feet so we can have a very seamless discharge to wherever they need to go, whether it be home or rehab or a longer-term care facility. And then the other thing that we also do is this multidisciplinary tumor board, which I'll talk about a little bit later as well. So the role of the neurosurgeon, so us as surgeons, we love to operate. And operative intervention for these surgical pathologies is really, you know, a very powerful tool. What we can do is try to resect as much of the tumor as possible, and then this helps to get a tissue diagnosis. So if you have some lesion that you don't really know exactly what it is, you get a piece of that tissue and look at it under the microscope, do the genetic analysis, and it really helps to guide some of the next steps in terms of how to manage the pathology. So again, working with this multidisciplinary team, we get the initial diagnosis. We might work with patients as they go, if they have an episode of relapse. And then we also help to manage any of these operative neurologic conditions. So I'm going to go through a couple of case presentations so that we can show you what our role as a neurosurgeon is. So we had a 74-year-old lady who came in with some progressive vision loss in her left eye. Her neuro-ophthalmologist decided to work it up a little bit more and then had some MRI imaging that was done. And she had this large lesion that you could see that was compressing a lot of very important structures within the brain. So here I circled a couple, you know, really important blood vessels that this big tumor is pressing up against. It was also causing a lot of pressure on the nerve to her vision. And so we took her to the operating room and we took the tumor out. It was really important for us to preserve the blood vessels because we didn't want to cause any strokes. And then we also wanted to make sure that we decompress the nerve so that she could preserve the visual function in that eye. So while she was getting worked up, while she was in the hospital, and even after the hospital stay, the whole team was made up of so many different people. She had her neurosurgeon involved, the ophthalmologist, the neuro-oncology team, and radiation oncology team that was involved. And our neuropathologist was also very helpful for the diagnosis. She actually did really well. And was discharged from the hospital after, you know, only a couple days. And she does continue to have some intermittent blurry vision, but overall she's she's doing really, really well. Sometimes when you have these deficits, though, all the surgery in the world will not help your nervous system recover. So the blurry vision, I think, is a very good outcome given all the different structures that we are working around. So she had an excellent surgery. She had maximal safe resection. We were very carefully able to preserve these important blood vessels to prevent any strokes. And then also we were able to preserve the level of vision that she currently had. This is another case presentation that we have. It's a 66-year-old gentleman. And he really just had this issue with intermittent tunnel vision. And so he also got a workup. And that it included an MRI of the brain. And he had this large lesion right here, which is kind of seated at the skull base, just behind his eyes, likely a meningioma, and it was causing some swelling and irritation to the brain tissue as well. So here I've circled these 2 tiny blood vessels, these little white circles or white dots here. And these blood vessels are very important because they supply a part of the brain that controls the motor function to your legs. So imagine if you didn't have a skilled surgeon and they accidentally, snag these blood vessels, one could possibly wake up weak in your leg, and that's something that would be very, very difficult to recover from. However, he also underwent a great surgery, had the tumor resected, and we were able to save those little blood vessels. And this was his care team, the neurosurgeon, the ophthalmologist, as well as our neuropathology colleagues. And he did really well as well. He was discharged 2 days, I believe, after surgery. And really the only complaint that he has right now is that sometimes when he exercises, he has a metallic smell or like a chemical kind of odor intermittently. But again, he had an excellent surgery, careful preservation of those blood vessels, and we were able to avoid stroke, and he went home, and he's about to retire and move to a warmer climate soon. We have another patient, a 34-year-old lady with right-sided hearing loss and dizziness. And mind you, some of these symptoms that people come, present to us with are very, very, just kind of like vague and sometimes mild presentations. Other times they can be very, alarming. It could be a seizure or profound weakness. So the range of symptoms that a person experiences can be very, very different. She presented with a tumor that looked like this, where it was very large, a lot of mass effect on her brain stem. And then this is where the hearing and balance nerve go out. So this explains why she was having those issues with her hearing. And then here you can see how the brain stem, this is the part that basically controls your brain or connects the brain to the rest of your body, is very squished and deformed and trying to coexist happily in this very, very small space, but not really successful in doing so. She had a very good surgery, and you can see that the tumor is resected here. And then some of that pressure on her brainstem is relieved. So we had a lot of very important people help us out here. Our neurocritical care team was essential for her postoperative care. Our neuro-otology team was also very helpful intraoperatively, so they help out with the surgery. And then our neuropathologist and neuroradiology team was very helpful as well in terms of guiding us in terms of the pathology, as well as bringing to attention any important structures on the imaging studies that we may have missed. This patient also did really well, and she does have right-sided hearing loss, but she had an excellent surgery with maximum safe resection of her tumor. The brainstem is decompressed, and then what was really important to us as a neurosurgical team was that her facial function was preserved, because sometimes when you work around the hearing and balance nerves, if the facial nerve gets severed or damaged in any way, it can cause some significant weakness, and that can be pretty debilitating. Sometimes with tumors this size, you can have some temporary facial weakness, but really our goal is to use all the tools and skills that we have in the operating room to preserve all the function that we possibly can. Here we have a 40-year-old gentleman. He presented with headaches, blurry vision, and intermittent weakness. This is, kind of vague symptoms. He presented to the hospital and was actually had a pneumonia or a type of respiratory illness, but then also had this imaging finding on his MRI. It's a very large tumor, very deep inside the brain, kind of in a scary area to work in. And it was causing some like fluid to back up in his brain, causing his ventricles to also be enlarged. He underwent surgery and we took the tumor out. And this case was very important because we had such a big team. Our critical care staff after surgery, our neuro-oncology team was essential for his case. Our radiation oncology team was also very essential for this patient. Neuropathology and neuroradiology were also incredibly important as well, because they helped us identify and diagnose this tumor so he could get the appropriate treatment necessary. So he did really well from surgery. He ended up going home 2 days post-op. And currently he just has some limited restriction in his eyes when he tries to look up, but he can overcome that just by tilting his head up. So he had an excellent surgery. We took out as much of that tumor as possible, and he was able to undergo chemotherapy and radiation that was appropriate for his diagnosis. So, again, our role as a neurosurgeon is to do that operative intervention for neurosurgical pathologies. We do the best safe maximal resection, or if it's a pathology that really doesn't allow for huge resections, and what we can do is a biopsy so that we can get a tissue diagnosis. We work within a huge multidisciplinary team to help out with that initial diagnosis, to help out with any sort of relapse that might happen. And then we also help to manage any of these other operative neurosurgical conditions. So one other thing that we do here at Yale is a very comprehensive assessment of the patient with a multidisciplinary team, and that also includes some research studies that include genomics for the tumor. So we take the tumor specimen and we sequence the whole genome of the tumor so that we can identify different mutations that might contribute to the pathology of the tumor. And then sometimes it can even help with the management of the tumor afterwards too, to help guide treatment planning. One example of where the genomics results helped to guide treatment, there was a 59-year-old lady. She had surgery by a different surgeon a couple of years ago in 2022 and had a little bit of residual disease, as you can see here. She had a repeat scan that was done about a couple months after surgery. And you can see that there's some areas of the tumor that seem to be growing and progressing already shortly after surgery. And for something to grow at this rate, it would be a little bit concerning for us, and we'd want to have a better understanding of the tumor. So the decision was you can either radiate it, you can reoperate, or just observe. And when we looked at the molecular analysis of the tumor, we saw that it was a meningioma, a WHO grade 1, which one would think is the most benign variety of the meningiomas. But when we did the whole sequencing of the tumor, we found a lot of mutations that would make it a little bit more atypical in nature, so that we would want to treat it a little bit more aggressively. So we ended up taking her back to surgery. She had a resection of the tumor and ended up having the rest of that residual tumor taken out. And then all this, knowing the genetics of the tumor really helped to make that decision of either taking out the rest of that tumor, trying to get the most out as possible, versus just leaving it be or radiating it. So this is sort of the workflow in terms of the brain tumor, the precision medicine part of our brain tumor treatment program. So you have your diagnosis, your progression or recurrence of the tumor. We either take it out and we can compare it to a prior sample if we have one. We compare the genomic profiling of it, and this is where we all discuss it at our tumor board. And then what that does in this whole cycle of research and discovery is that, we can enroll patients in clinical trials, we can learn more about the molecular aspects of the disease, and then we can also work on understanding what might happen after treatment. One example would be some of the studies that we've done with the TIGIT trial, which I believe Dr. Blondin might discuss as well. And so all of this is a very circular, it's a very cyclic type of thing where we study the tumor, understand what treatment does to it, learn more about the tumor to help guide the next steps for our patients' care. So all of these patients, they benefited from having a really experienced and coordinated care team. And then, of course, this technical expertise that Yale, Dr. Moliterno, Dr. Blondin, Dr. Barden, the whole care team, it's such a well-oiled machine here that these patients have relatively shorter hospital stays compared to a place that would not have the same kind of expertise. They have excellent resections of their tumors, and they also may leave with some neurologic deficit if there is some to begin with. But usually what we do, we take so many precautions in the operating room that most people have very minimal neurologic deficits. And the other thing that we contribute with these tumor tissues is the genomic analysis of all the tumors. So, what we really want to focus on is getting the high quality of care so that we can have the best outcomes for our patients, so that we can get everybody together to create a plan that allows everybody to go back to a high level of function and get into the necessary treatments for their tumor pathologies. So with that, I just wanted to thank everybody for listening. These are some action shots in the operating room. So it really takes a village. On the right side here is Dr. Moliterno and all of us that help out in the operating room. And then this is actually a case from today where you can see down here, we have so many different specimens that, all our patients very generously, donate their tissues to, so that we can study all the tumors and learn more about them. So thank you to all the patients that have contributed to the future of science. And that's all for me.
Thanks, Dr. Kim. That was really tremendous. I'll add on that in my practice as a neuro-oncologist, our molecular profiling of tumors is just absolutely key to my practice. It's really transformed the way that I view brain tumors over the last 6 years. And it helps me be more educated about chemotherapy recommendations for my patients, can help me get kind of a more accurate prognosis for patients. There really has been one major advance. So the therapeutic or treatment options still haven't really caught up yet, but our understanding of the biology has improved pretty significantly in the last several years. And I think our efforts at Yale in particular have been pretty important. Dr. Moliterno had some important work on the genetics of meningiomas, published several years ago now, but yeah, it's really moved the field forward, and we have a better understanding now of meningiomas, just as you were saying. I know that scan. So I'll share my presentation on couple points related to clinical trials. Something I'm very passionate about. I think clinical trials are very important for brain tumor patients, and in particular, glioblastoma patients, because of the limitation that we have in the current therapies. As I mentioned before, we really, unfortunately, only have a few therapies which have proven benefit for glioblastoma, those being temozolomide, Avastin, or bevacizumab, an Optune device, and then another chemotherapy called lomustine. And beyond that, everything else is really hasn't been proven to be effective, and we need to develop new treatments. And I've seen a number of patients in my practice that have entered into clinical trials, received clinical trial treatment, and have done done better than the statistics. Their treatments for their particular tumor have really worked, and it's just tremendous. So I think clinical trials are very important to consider for all patients. And they are research, though. It's done with a lot of oversight for good reason. And we want, with that research to test new therapies, medical, sometimes or surgical or radiation in people. And these ultimately determine if a treatment is safe and effective to treat tumor types. So there's different phases of clinical trial research. The clinical trials in people, but even before phase 1 or the first in human studies, drugs undergo extensive lab testing and identification in lab models that they may be effective against glioblastoma. So when a molecule is being developed, it first is found to have effect to kill glioblastoma cells in a culture or like a dish. Then usually tests are done on animals like mice that have glioblastoma tumors that can grow in them to see if it has some activity there. And then once it seems to have effect in lab models and animal models, we go into phase 1 or first in human studies. Then if a drug is found to be safe in phase 1 studies, not causing significant toxicity to people, it can move on to phase 2, kind of an intermediate step where we test more people with that drug. We gain more information on the safety and also some preliminary signs of effectiveness of the drug. And then if the drug seems to be effective in the small number of people tested in phase 2, it's tested in a larger group of people, usually several hundred people for glioblastoma studies in a phase 3 study. If the drug is effective in phase 3 compared to a group of folks who receive regular therapy without the experimental drug, then it can move on and get FDA approval and become a new tool in my arsenal to defeat GBM. So proud to report we still have a pretty extensive portfolio of products for different neuro-oncology indications. And I think it's very important for Yale as a center to be able to offer clinical trials to treatment multiple brain tumor types. We have the most number of trials for glioblastoma, it being the most common malignant brain tumor in adults. 2 of the studies are run through networks, one called the Global Coalition for Adaptive Research, or GCAR, which is running the GBM Agile study, a platform study, which I'll get to with the next couple slides. We also are a member of a new research consortium called the Glioblastoma Therapeutics Network. This is a group of major academic medical centers that's funded by the National Institutes of Health and our taxpayer dollars to investigate new therapies for glioblastoma. I think it's pretty exciting. Yale's member of this group. The study is planned to test multiple drugs. One drug is being tested currently called brigamadlin, which is a molecular inhibitor that may be effective in MGMT unmethylated glioblastomas. Then we have some biotech startup type companies testing products, one an immunotherapy product called AB154, and one being another kind of molecular drug called FBPMT. So Yale is the lead site for both of these. Yale's the only site for the nanopharmaceutical study. So I think it's exciting that we're able to offer these novel therapies to our patients. Both the ARCUS and the nano pharmaceuticals are phase 1 studies. Then we're in a consortium called the Alliance. It's another medical consortium of many cancer hospitals. We have a study for patients with oligodendrogliomas, comparing 2 chemotherapy regimens called CODEL, and a study testing drugs for meningiomas. Meningiomas have different molecular subtypes, it turns out, as we've learned from the molecular analysis, and different subtypes can be targeted potentially with different drugs. So one subtype known as AKT1 mutant meningioma, which usually grows in the frontal area kind of above the nose, may be susceptible to a drug called capivasertib. And we are site testing that molecule in patients. We also have studies for CNS lymphoma, investigating some new drugs, which seem to be effective in other lymphoma types. And we're a site for a drug being tested for diffuse midline glioma, or DMG, an aggressive brain tumor that typically occurs in children and young adults. And we're hopeful that this drug will be effective. This one is actually a phase 3 study. Again, hopefully the study will be completed as soon as possible, and we'll just get the answer to whether this drug is effective for that tumor type or not. So with the GBM Agile study, it's looking at both newly diagnosed and recurrent glioblastoma patients. And it's known as a platform study. So the drug is the study is a platform to test multiple drugs against the current standard of care. Current standard of care being radiation and temozolomide, as Dr. Barden showed in earlier slides, or lomustine for recurrent glioblastoma. And the study is designed with multiple arms that can be tested and an adaptive design randomization, meaning that patients are assigned into treatment groups based on their own particular biomarkers for their tumor and the performance of that treatment, how it's looking based on the number of people that have been enrolled already. So if a drug is enrolled, seems to be promising and patients enrolled, more patients could be randomized into that arm potentially. And then there's only one standard treatment arm compared to multiple experimental arms. It increases the chance patients can get into experimental therapy arms rather than more classical clinical trials where you'd have one group of standard treatment and one group of experimental. So that's also an advantage of this. We have it open in New Haven and Trumbull. We've enrolled, we've been open since 2019 for this study. We've enrolled over 70 patients into treatment so far. There's been some different arms tested. The study is designed initially to test products in a phase 2 strategy. And then if the drug is looking effective. It can graduate to phase 3 with more patients being enrolled. Sadly, the first 3 drugs which were tested did not graduate to phase 3. Their patient outcomes and survival times were not superior to those seen with the standard treatment arm. So those did not graduate. Development is stopped on those products, but at least we got the answer. In particular with VAL-083, that study was completed in less than 2 years from starting GBM Agile to the results. It didn't graduate. So relatively less time was spent figuring that out compared to other clinical trials. And that's also a positive for just patients in general that get glioblastoma. So there's 3 arms currently open, looking at different strategies, those being the VT1021, a molecular inhibitor, troriluzole, an oral drug that reduces glutamate, a neurotransmitter involved in tumor growth, and ADIPEG-20, an injectable drug, which works to deplete arginine, an essential amino acid from tumor cells. I'm one of the national investigators for the ADIPEG-20 treatment arm. We've enrolled a few patients thus far. We will see how things go with that treatment. And then, as I touched on, Yale is a member of some exciting consortiums, the Glioblastoma Therapeutics Network, or GTN, funded with NIH, an NIH grant, and another group called the DNA Damage Response Consortium. This is funded by the National Brain Tumor Society. Dr. Bindra in our radiation oncology department is one of the leaders in this particular project. So new treatments are developed through clinical trials. I think we have an exciting portfolio, have some other things in activation. We're getting more excited about cell therapy. There's been reports that CAR T may have effectiveness in glioblastoma and other cellular therapies. So interested in looking into getting that research going at our center. And then we have a weekly team meeting to identify potential patients, review patients on treatment, and discuss new trials and studies in the activation process. So this goes in conjunction with our weekly tumor board meeting to discuss newly diagnosed patients and treatment planning for those patients. All right, I will stop there and so stop sharing screen, and we can transition to the Q&A section. All right, I'll read them as they're coming along. After a craniotomy, is it normal for the side of the head that surgery was on to get tighter as time goes on? And is it common for numbness or tightness in the head? We'll let Dr. Kim answer that on the surgery side.
Yeah, I've actually heard that happening before in some patients. It also depends on the treatment that they might receive. So if you get like radiation, it kind of changes the stuckness of your skin. The reason why a lot of people experience numbness is that when we make the incision, you basically have to cut through all those nerves that lead to the sensation of the skin. And sometimes it just takes time for those nerve endings to grow back. So a lot of people will have numbness if there's like a craniotomy right here, sometimes, you know, wherever the incision is. And the numbness may or may not improve over time. It really depends on how you heal as an individual.
Can you comment a little more just on the planning for the craniotomy piece, like replacing the bone, or maybe there are some instances where the bone isn't replaced, like, yeah, those kind of aspects of treatment.
Yeah, so what's really cool is that before surgery, as part of the surgical planning, we get an MRI that's a really thin cut, and we also get a CT scan. And that helps us make, I call it like the GPS system, like a navigation system in the operating room, using like your face features and everything. So once we can identify exactly where that tumor is, then we can plan our incision. Sometimes it's a curve, sometimes it's a line, sometimes it's like a headband across the top of your head, just so that it can help with our access. For certain tumors, like let's say a meningioma, right? They can be involving the covering of the brain, and sometimes it, grows into the bone and involves the bone underneath as well. If the bone seems to be very involved with the tumor, the last thing we want to do is put tumor back in after we take tumor out. So if that's the case and the bone seems to be really involved, then we'll use something else like a mesh, a titanium mesh, to replace that bone and then cover it up with the skin. So it really depends on how things look in the operating room sometimes. And then if the brain looks really angry and it needs a little bit of time or room to swell, then giving that extra space with the mesh is really helpful for patient recovery too.
Yeah, that's I've seen Dr. Moliterno can identify when meningiomas invade into the bone, and by using a mesh to repair the skull defect rather than replacing the diseased bone, patients are having better outcomes from that.
Yeah,
That's
yeah.
pretty.
And it's cool because you can kind of tell sometimes based on the imaging study. So if you get like an MRI or a CT, you can almost tell if the bone seems to be involved. But honestly, you really don't know 100% until you get in there and actually physically look at the bone.
All right. Next question. Any thoughts on why the prevalence of brain tumors seems to be increasing? Dr. Barden?
I don't know. I wonder, so one of the figures that I showed earlier, the pie graph there, that's called, or that comes from, we call the CB Trust, so the Central Brain Tumor Registry of the United States. And that's really what we refer to. It takes, it takes into account all the diagnoses of brain tumors and sort of factors with it, overall survival. And it looks at not in the most, so the one that I showed you, I think was from like 2013 to 2017, that sort of year period. And that was the report that came out last year. So it doesn't look at the most recent years because it takes time to collect all that data. So it kind of looks at a 5-year period, a few years back, and each year it comes out and it creeps a little bit more forward. So all of that is to say it feels like brain tumor frequency is increasing, and particularly in a young population, but it's hard because I'm on the ground and seeing it every day, and it just feels like that's the case. But we know as scientists that what things feel like isn't always the rational thing. So I guess I'll start by saying I don't know how much it's actually increasing because we don't have those numbers for the recent years yet. We will. But I suspect that it might. We're certainly seeing that with other cancers. Colon cancer, for example, the prevalence of that is increasing, particularly in a younger population. I can only speculate as to why. I know that they've certainly done large population-based studies on things like cell phones, electromagnetic radiation, and all of those haven't really turned up as causes in the investigations that have been done. There's very few like clear risk factors for primary brain tumors, and they don't apply to the majority of the population. Most people have not been exposed to extremely high doses of ionizing radiation. They weren't in the fallout zone of Chernobyl or didn't get, radiation for leukemia as a child. Those are really the rare circumstances where we know there's an increased risk. I know that I know and I hope that we'll learn more with time and identify clear risk factors for these types of primary brain tumors like we have in other types of cancers. But I don't have a good answer for that. There's a long-winded answer, I guess.
Yeah, agree. It's difficult to really know at being in this field if things really are increasing, or if because we're in the field, we just see a lot of it. So those public health monitoring systems are important, but they do lag. I personally think probably pollution plays some role in this. Plastics and other carcinogens are known to be associated with cancer. And glioblastoma typically is a disease of older adults. Prevalence increases with age. It's also a little more common in men than women for reasons that are not clear. I think it has been pretty well definitively proven that cell phones are not associated. Like your skull bone is strong enough to prevent cell phone RF from going in. But yeah, I think it's important to have environmental protection and obviously support clean water, clean air. These are the ways to decrease cancer risks in the future for the population, I believe. All right, the next question, thoughts on fusion plus testing 3D. And what does methylation testing repeated by the NIH bring to the table? Are you familiar with protein biodiagnostics? I was not familiar, but I just Googled that. It looks like it's a kind of a testing platform for the molecular testing that we do in-house at Yale. That's just like our molecular profiling. So get a mutation report. And also we have kind of a system where we can look for chromosome alterations, gains or losses of chromosome fragments and chromosome damage, which is really even superior to a lot of the commercial testing platforms. The ones I'm familiar with are Caris, Foundation Medicine, and Tempus. So glioblastoma seems to be a disease of abnormal chromosomes, not a single mutation or not one DNA point mutation. And that's made it difficult to treat. It can't be targeted with a targeted therapy like certain cancers, like ALK mutated lung cancer due to an ALK mutation. Glioblastoma has chromosomal alterations, and you can't target that with molecular drugs yet. Then the next question, if a patient's in Agile at another hospital receiving VT1021 or one of the study treatments, is it possible to receive treatment at Yale? I would say it may be possible to switch your site if you're in a clinical trial that another hospital has open. That needs to be coordinated by your treating doctor, like the treating team, the doctor that would take on your case at the new hospital, and the study team. With that being said, I have had patients of mine in clinical trials who move out of state and have been able to continue on study treatment in their new state because the hospital where they established care also had that study. So that is potentially possible. Well, we've answered it all. I appreciate everyone joining. Yeah, I sincerely hope that next year we'll have some more exciting breakthroughs to share with you all. We'll keep up the battle. We'll close it out there. Thanks everyone for joining.
Thanks, everyone.
Thank you, guys.